MA insurance. And also we observed that during the pandemic, this shift from the institutional setting to the home-based setting has accelerated. However, some of the challenges that we are not able to address currently is, first of all, there is a significant lack of evidence, clinical evidence, and also the evidence from the families and caregivers about what is the best post-acute care for them from different perspectives. And without those evidence, it is difficult to really optimize decision-making for the parties that involved in this process and really drive improvement. And so it's crucial to understand the values. And some of the values that I will be discussing today, the first aspect is from the patients and caregivers' perspective and how they value and received the post-acute care from different settings across with different characteristics. And second of all, there is barriers for transitioning from institutional settings to home-based settings, at least for some of the disadvantaged population, and we want to identify what those barriers are. So first project, I try to elicit the preference for post-acute care between the home health settings and the skilled nursing facility settings using a discrete choice experiment. So let's take a closer look between the two settings. So as of 2017, there is more than 15,000 skilled nursing facilities and around 12,000 home health agencies were in operation in the United States. And skilled nursing facilities and home health agencies has the largest share of the patients they would provide service with and the expertise they offered, and also the services that they could provide. And during the time of the post-acute care discharge process, patients and caregivers need to weigh the different trade-off between those post-acute care settings. In terms of the quality of care, the time it takes for the patients to recover, the cost that involved in the care process, and the location, whether it's close to their families and their caregivers, and also how much time it really takes caregivers in different scenarios of the post-acute care arrangement. So as I've mentioned, there is strong policy interest on using the less intensive post-acute care, and pandemic has accelerated this process, but we really don't know whether those policy shifts is aligned with patients and caregivers' preference and their needs, family circumstances. And second, is home-based care truly preferred by our people, by patients, and maybe equally importantly, by their caregivers who devoted a large amount of time at the same time for their family members. And additionally, I'm trying to answer how do individuals really evaluate the trade-offs among different characteristics of the post-acute care in terms of locations, their room arrangement, quality of care, and cost, and etc. And lastly, how do those preferences among the patients and caregiver really varied across different type of people with certain socioeconomic backgrounds? So this research used discrete choice experiment, and here is an example of the survey design. And this survey involves carefully crafted survey instrument to simulate the real-world decision-making process for the patients and for the caregiver when they face the post-acute care choices. And the respondents were required to answer those choices questions to think about from a patient's perspective or from a caregiver's perspective. And during those decision-making, they would trade off the attributes as I listed here, the travel time from your home, room type, whether you will stay in skilled nursing facility in a private room, a semi-private room, or stay at home, and the overall quality of care indicated by the star rating that's presented on the national website, ranging from below average quality of care to the much above quality of care, also including the average quality of care. and also the time that the primary caregiver from a family needs to taking care of you during this process. And the time range from 0 hours, considering in a skilled nursing facility, people don't have to take some time to take care of their family, to 8 hours per day. When we considering some people need extensive assistance at the very beginning of their post-acute care recovery. And the recovery period range from 15 days to 45 days. It's a way we use as an indicator for quality of care in some way. And also the total amount of out-of-pocket cost you will pay for your post-acute care episode. Do you have a question? Yes. About the extent that people like
in my head, I can say something. It's definitely the process. Yeah, both sides. And they go home and it's
yeah, and this type of the changing preference over time or after a certain type of event, it's evident in some of the decision theory literatures, and yes, and this could be anticipated.
So you mentioned that you interviewed experts. Did you actually interview patients and caregivers really specifically?
Yes, I did. I was going to talk about that in a moment, but that's a great question. But in terms of the attributes that we solicited to carve out this design beyond the literature review and expert interview, we also look into the literature for the past 15 years, mostly from the qualitative study that what the patients and their caregiver really described that the characteristics that matter them the most during the post-acute care discharge process. And also, I conducted a series of pilot studies, including validating the understanding of the survey in the local communities and in some of the patients group, and then sequentially use additional pilot study to narrow down the levels of attributes that are included in the study design to get the most information from this survey experiment. And another thing that I want to mention is during the design of the survey instructions and the description of the scenario, we try to design it in a way that the patients and the caregiver will focus on those attributes and the post-acute care settings instead of focusing more on the clinical aspects and the implication of those settings. And we would let them to assume that those are comparable out of those choices. Yeah, it's more about a personal choice question instead of a clinical, a clinical decision. Yes, and this study, I used American Life Panel, which is an internet-based national representative sample remained by rand, and I recruited 1,555 sample and divided them into two groups. One half, I will ask them to make decisions for themselves as a patient, and for the other half, I will ask them to make decision for their as a primary caregiver for their family members. And I focus on the respondents who are age 45 and above, since those are the populations who may face those type of decisions in their life or making decisions for their family members. And in their survey design, I included two clinical conditions, which is hip fracture and stroke. Since those two require are different type of conditions, one is surgical, one is medical, and they require different type of physical therapy and rehabilitative service. So that's the reason why. So on to the next slide. Yeah, so why I would use discrete twist experiment instead of some of the reviewed preference to see where people actually go in the real world. Since it really helps us to overcome some of the difficulties that we really can observe in the real life behaviors. And some of the reason is when people make those rush decisions, there are often lack of information on the quality of care and what are the outcomes that following those choices and the implications. And also the real world choices are largely driven by availabilities of different type of services and financial incentives, and also some of the power dynamic between the physicians and their family members and the patients. So this experiment can really separate the preference from the caregiver's perspective and the patient's perspective. For here, the analytical framework is that I used an economic model that that's really using the theory of the utility maximization, which I wouldn't really talk at length here, but it involves a lot of models, including the basic biologic model, mixed logic model with the alternative attributes, and also the random parameters for some of the coefficient to capture the heterogeneities in the people's preference. So here is the first main set of the results. It shows the patients and caregivers' willingness to pay for each post-acute care attributes per day. And the blue bar here represents the patients, and the orange bar here represents the caregivers, and the y-axis represents the amount of willingness to pay for each attributes on different attributes. For each attributes, and there are positive values and negative values. The positive values, it's straightforward. It means how much they're willing to pay for certain type of characteristics of the post-acute care services. And the negative value are those the amount they are trying to pay to avoid certain type of post-acute care services. And from this graph, you can see people have strong preference for home-based care from the first two bars here. From the first two bars there. And since they have around $50 more willingness to pay per day for the patients to stay at home compared to those who will go into skilled nursing facilities. And additionally, you can see there is a significant amount of willingness to pay for people to go into higher quality of care, both for the skilled nursing facilities and for the home health agencies. And additionally, in the quality of care, the thing that people are most pay attention to is to avoid below average care indicated from those graphs. And you can also see that the caregivers actually are willing to pay more for the patients to stay at a higher quality of care service, since which indicated that they maybe care more about their cared one's quality of care. Yes. So each patient get 8 scenarios, and since there is tons of permutation, because I have a lot of attributes and the levels, so I use the D-efficient design and also the orthogonal design at the very beginning to try to get what is the average point estimate for certain coefficients on the attributes, and then trying to simulate different combinations of choices to see what yield the most powerful the statistical power for those analyses. So that's the process how it's done. 6. Yes, each some of them have more than 3 levels. Some of them only have two levels. Yes. Yeah. 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 Yes. So I did that use the pilot study online that is not the formal survey sample. I'm trying to estimate what is the most powerful way of design those attributes and surveys. And it end up with 48 combinations of choices that randomly showed to the participant, and each one would get 8 scenarios to choose from. Yeah. Yes. Yeah. It's coded in a way that the different attributes actually random showed from the top to the end. Yes. And here is the second set of the result, which show the heterogeneity of willingness to pay for people to stay at home compared to going to skilled nursing facilities. And those are the ones that show the significant difference across within the socioeconomic groups. And this is for the caregiver's perspective. And you can see when people have prior past experience with home health agencies, they would have a higher willingness to pay for home-based care. And when they have more job securities, or they would have a higher willingness to pay for the home-based care. And also, yeah. Mm-hmm.
And thinking back to when I had to make some decisions for my father.
Yes.
Is it willingness to spend my money or willingness to spend their money?
Yes. That's a great question that we had a lot of debate on when we designed the survey. And then the way we frame it is from your family. So at that point, we kind of let them trying to figure out what is the best way. And since different families have different preference on how the financial arrangement would be, but average out across all the populations, we should get an average across different type of financial arrangement. That's the original consideration. Yeah, but that's a really great question that we debated a lot over.
Small.
First of all, it's if we look at this graph, which is the average willingness to pay from across different attributes for patients and caregivers, it's an average. It's average across different populations, and those I need to point out those numbers are comparative. So, for example, for the willingness to pay to go back to home with home health agencies, it's actually is the comparison relative to the patients would stay at a skilled nursing facility using a shared room. Yeah. And we try in the back end, we also try to validate whether those experiments are meaningful since they are thought process. And some of the evidence we have from the private shopper information is that people are willing to pay around $170 more for the people to go into private room compared to a shared room. And we have the statistics here to estimate what is the difference between per day going into a private room and from a shared room. And that's aligned with the real world data. Yes.
Back to the question. Being involved, how much it's going. The direction.
Yes. And I think this type of, I think they also, they both point out a really important question. And beyond the preference itself, it's also get into the subtlety about the relative preference compared to the different attributes. So when you really think about the decision-making process for a patient at a certain time during the post-acute care discharge, you can come up with two scenarios. And if those are the metrics that we have here, you can actually calculate which one they actually prefer at the end with those numbers here. And yeah, back to this heterogeneous preference for the caregivers for patients to stay at a skilled nursing facility compared to home health agencies, we can see female are willing to pay more for their cared ones to stay at home compared to the male caregivers. Additionally, who are employed has a lower willingness to pay compared to the non-employed caregivers. And so this indicated that if you, I didn't show it here, but if you combine this figure with the numbers that we have from the previous figure, we can actually calculate when is the time that a patient or a caregiver would tilt towards skilled nursing facility compared to prefer staying at home. And one thing that I've learned is when the patients or the caregivers need caregiver time exceed 8 hours per day, they actually preferred their family members to go into skilled nursing facilities. So really the socioeconomic challenge such as the insecurity job would change caregivers' preference towards where the patients should go.
Just thinking, you know, if you're a lower income person, you're living in an apartment. And we require to get down, then, you know, the standalone, maybe want to.
Yes, so I've actually looked into more than 50 socioeconomic factors, including the living conditions, living in the apartment, in a big building or single family home, and also the income. But for the caregivers, those factors didn't stand out as at least statistical significant as their distributions. I think maybe one of the reasons is I have limited number of samples here, and if we extend the sample, we may find additional implication for those factors. And yeah. That's the observed characteristics. So yes, yeah. So when they maintain this international based survey, they basically send out those demographic questions every year to capture the timely change of their arrangement, and you will see all the factors, including how they view their self-care and the general health, and how many family givers really co-residing within their primary residence. Yes, and here let's see. Yeah, and when we look at the heterogeneities across different patients groups, we observe 3 factors that really impact their decision. 2 being the past experience with skilled nursing facilities and home health agencies. When they are more familiar with the skilled nursing and home health settings, they would pay a lot more to go back home with home-based care. And this is consistent with the caregiver's perspective as well, which pointing to the prior knowledge about the actual care in those settings really matters when they make the decisions. And the education informed decision with sufficient information is really important at the time of discharge. And yeah, here for the patients, it actually matters for their family, for their primary family income, probably because they imagine themselves being the primary payers for those type of care. But when they have higher family income, they I think that may be more adequate to go into the home-based settings. So some of the limitations for this study, it's only focusing on the sample who are aged 45 and above, and specifically just two scenarios, hip fracture and stroke cases. So it may have limited generalizability to other patients groups and health conditions. But those are the important demographic groups and the prevalent conditions that require post-acute care. And the implication and conclusions that from this study, it's first of all, it reviews the preference for high quality and home-based post-acute care. Even though we know those type of facts anecdotally, but in the literature, we haven't really have any evidence on this area. Additionally, the policy shift towards the home-based care, we can confirm is largely aligned with the caregiver and patient's preference. However, we need to make sure that there is an equitable transition to provide sufficient family and caregiver support to make sure all the demographics and socioeconomic groups really get the benefit of shifting themselves to the home-based settings for post-acute care. And lastly, I've touched it briefly, it's that enhanced awareness and the knowledge about post-acute care is crucial for their decision-making process. And so I'll pause here for any additional questions on this study. And yes. Yeah, that's a great question. Yeah. So in the description, we describe it in a way that they need different type of physical therapies for language therapy or for speech therapy. And at the end, they will recover to a time that before their acute post-acute care level. That's the way we describe it to disentangle the clinical implication of how it will influence the people's preference. But that's an interesting question that can be explored in the future. Yes. Yeah. Yeah. So
I guess I would frame it another way. Among your expert opinions, did you ever have sort of the clinician recommendation within the choice? Because frankly, that's often a situation where the clinician is recommending home health or recommending skilled nursing facility, and to the extent that someone feels they have a choice, they may have to weigh differing from the recommendation of the clinician.
That's a great point. And when I think about this question, I think about the clinician's perspective more on the emphasis of which settings would help you recover better. And so in that sense, I was considering that in my next research projects, which emphasize on the clinical insights, but only focusing on the patients and caregivers' preference. However, there's another project that is ongoing and I'm writing the proposal on is that I have the EHR data from California, and they record what is the physician's recommendation for where the people should go, and I want to compare those recommendations to where the actual discharge destination is, and see what is the influence on the physician and potentially maybe the influence of the insurance on the dynamic of those on those recommendations.
Is there a policy about
Yes. Yes. Mhm. Network. Yes. That's also, yeah, the insights I gained from talking to some of the clinicians in mass. So basically, from my understanding, the clinicians don't get much involved in this discharge planning process. It's rather the discharge planners and the physical therapists who make recommendations. And it is now required that the discharge planners present a list of the choices to the patients at the time of their discharge. And usually the patients will dial what is the available choices there and whether they have an empty bed, and then making the decisions from there. Yeah. Yes. I haven't. Yeah, so I haven't looked into that. I haven't looked into that yet, but I think that's a very interesting question to explore, definitely. Yeah, and solve the questions from both the patient side and the caregiver side.
I have one idea.
Sounds great. And something I would definitely look excited to look into is the implications of those discharge, not only on the patient, but on their family caregivers. Yes. And this is also related to my next project. Yeah. And should I move to the next? No, yeah. So the next one is trying to collect the clinical evidence and inform the decision-making for post-acute care, specifically between the skilled nursing facility settings and the home-based settings, using an instrumental variable analysis. I'll explain what that is. And so I just want to provide a roadmap of this study. I aimed to understand the heterogeneous treatment effect in different disease cohorts during the after the post-acute care discharge. And if I have those type of clinical insights or evidence, it will allow us to inform the clinical guidelines for post-acute care discharge and guiding the decision-making to achieve the optimal clinical outcomes. And also it will be provided the needed evidence to incentivize the cost-effective post-acute care services. And my key hypothesis here is there is no adverse outcomes with the use of less intensive setting, but at the same time will save Medicare cost. And my findings is there is no significant difference in 30-day all-cause mortality rate and 30-day all-cause rehospitalization rate. And however, there is a significant higher Medicare spending when patients were sent to skilled nursing facilities. So some of the existing literature, I wouldn't read all of them, but the high-level takeaway is that the main focus in the literature is across the different institutional settings in the past between the inpatient rehabilitative facilities and skilled nursing facilities, and some indicating there is better physical function recovery in rehabilitative facilities. And I conducted a systematic review, included all the studies in the past 15 years on the comparative outcome across different post-acute care settings. And there is no consensus and very limited evidence on what is the comparative outcome between the skilled nursing facilities and home health agencies. And part of the reason is there is such a large heterogeneity across patients and caregivers in terms of their health conditions, their socioeconomic background, and whether they will have sufficient food and living support. And the patients have various primary diseases, severity of diseases, and comorbidities make it difficult to have a consensus on what is the best setting for a certain patient. And so that's something that I'm trying to achieve in my study to understand the implication of the different settings on patients' health outcomes and address the selection issues here. So yeah. So maybe I will talk a little bit about the selection issue. In the healthcare studies, normally we cannot get the full information of a patient. So and you cannot really randomize people across different settings to study the health outcomes, and that's the selection issues that I want to address. And for the study population and the outcomes, I focus on the traditional Medicare patients between 2013 and 2017 who has hospitalized for more than 2 days and have their inpatient record in the MedPAR data. And I identified 3 patients groups with the primary diagnosis of stroke, congestive heart failure, and hip fracture during the index hospitalization. And I also excluded patients who passed away in the hospital and who were discharged to hospice service. Additionally, the people who have previously stayed in the skilled nursing facilities prior to the hospital, to the index hospitalization were also excluded, since they usually use post-acute care in different patterns compared to the other people. And the study outcome that I focused on is the all-cause 30-day rehospitalization rate and mortality rate, which is the standard measure of quality of care in those settings. And I also compare the post-acute care episodes spending up to the 180 days post-hospitalization. So here it's, I use the instrumental variable design. And by instrument, it means that it really randomized the people into different treatment, and they will impact the health outcome only through those randomized treatment. And the instrument I chose is the daily skilled nursing facility bed occupancy rate in its own respective post-acute care local market. And it indicated the supply of the skilled nursing facility services at the local market during the time when patients were discharged, and if it will influence the patient's choice for going into a skilled nursing facility versus home health agencies to some extent, and eventually impact the patient health outcomes to address some of the unobserved confoundings in our study. And there are 4 main assumptions, which I won't talk into details here, but if you have questions, I'm really happy to answer them. And here is some of the descriptive examples of the instrumental variable that I used, which is critical in understanding its impact on people's choice for going to the 2 different settings. And on the left-hand side is the occupancy rate in 2017 for a given hospital service market. And this is the hospital service market in Cambridge, MA. And you can see the fluctuation of the SNF bed occupancy rate across the whole year. And on the right-hand side is the average occupancy rate within a market across different geographic regions. And the average is around 60% of the occupancy. And based on the temporal and the spatial variations here, we, at the end of the analysis, we try to adjust the market and seasonal variation using year, quarterly, and market fixed effect. And here it's some evidence to show whether my instrument really worked. And here it's some of the characteristics of different patients groups across the market, across the time when there is a higher occupancy rate versus there is a lower occupancy rate. So this instrument should be randomized across those groups, which means that the patients in the higher or lower occupancy bed time should have similar characteristics. And from this table that we can see, there isn't a significant difference across the two groups within each cohort. And for the difference that we observed, additionally adjust for patient level covariance to have a better estimate. And those included a long list of patients' demographics and their median household income represented by the zip code that they reside in, their eligibilities of insurance, and also a series of conditions inferred from the Medicare claims data. And also, yeah. Sorry, what's that? Was that chose by? Yes. Yeah. Yes.
That balance is very at that threshold, if we can choose that threshold to 40%.
Yes. Yeah, that's the medium across the country. The medium occupancy rate across the country. Yes. Yes. Yeah. Yes. Yeah. Yeah.
Okay, now you're family or and actually daily or
yeah, I think it's both. It depends on the market and availability of the service and also the patient's volume at different times. So there's a variation on how it actually changed. And but we were trying to adjust for seasonal effects since it may actually impact patients' outcomes. So we wanted to just focusing on the random part of the skilled nursing facility occupancy rate. And when I presented this research at school, they pointed out this decision-making just depends on the volume of service or the availability of the local service at the time. It's itself an interesting question that I'm looking forward to dig it a little bit more in the future research. Yeah, so you pointed out a really important question. This is getting to a little bit details of how I calculate the occupancy rate. Since now in the long-term care focus or other data, when we talk about occupancy rate, it actually include both the short-term stay and the long-term stay in the skilled nursing facilities. So here I really want to capture the capacity of the short stay patients focusing on the post-acute care. So yeah. I did some of the calculation back there, but I would be happy to discuss in details with you later. Yeah. Yes, and here is the key sets of the result that I showed here. So when we use just a simple multivariate regression to adjust for the observed characteristics for patients, we can see the skilled nursing facility patients actually have a systematic higher 30-day mortality rate and rehospitalization rate, as well as the Medicare spending for post-acute care episode. But when we use the instrumental variable regression to trying to minimize the selection bias, we actually see the patients who got into the two setting has no statistical significant 30-day mortality rate difference and 30-day rehospitalization rate. And the difference in the Medicare spending for the episode also decreased a little bit, but the skilled nursing facilities still have a much higher spending for the for the patients who go there. And some of the study limitations that I have, first of all, my study is limited time frame in 2013 to 2017, and we've known that during the pandemic and also now there is ongoing changes about how the post-acute care delivered services in different settings, and the ongoing change about the payment models of home health agencies and skilled nursing facilities. So it indicated that there need to be ongoing studies to understand the clinical implication of those changes on the patients. And my study didn't include the Medicare Advantage beneficiaries, which limited our generalizability to the overall Medicare patients or beneficiary population. And something I was really looking forward to studying when I started this project is to understand the physical and cognitive recovery for those patients. But the issue right now is across different settings, they use different tools to measure the recovery, which make it impossible to compare across different post-acute care settings. But I think since last year, there is a demonstration to set up a new assessment tool across different settings. So hopefully I will be able to address this issue in the future. And lastly, it's the we need to pay attention to the interpretation of the instrumental variable estimate. First of all, it's different from the traditional regression analysis, and it's just the interpretation can only be applied to those subset of group who are influenced by the instrument, which means that those population need to their choices need to be impacted or changed by the instrument that we leveraged here. And yeah, so this is a start of this series of analysis that I'm hoping to do. Some of the importance of this type of research, it's really reveals critical insights to the clinical value of the post-acute care. We reveal there is no significant difference in mortality or rehospitalization between the two settings, at least for our 3 studied cohorts. And it's kind of challenged the belief that the skilled nursing facility usually provide better rehabilitative care for certain patients. And we also noticed that these 3 cohorts exhibit higher medical spending in the skilled nursing facility compared to home health agencies, which means that those 2 factors, the clinical outcome and the financial implication, should be considered at the same time when we think about the need for more cost-effective discharge planning that tailor to the patients. Some of the research that is ongoing is since instrumental variable is limited in its way to understand the heterogeneous treatment effect for populations. So I'm leveraging some of the deep instrumental variable analysis using machine learning method to actually elucidate the difference about those outcomes across a very small group of population. And yeah, that work is ongoing, and hopefully we'll have results soon. And there is the other study that I wanna. Oh, sorry, go ahead.
them. And so I'm wondering, you know, about setting your business program to that needs to limit that.
That's a great question. So, so it's not the focus of my study, but this instrument can definitely be applied to those questions. And something I try to do is to adjust it for to apply for the sniff fix effect in my analysis for the additional sensitivity analysis, which I didn't mention here. Yeah. Yes. Yeah.
Is there a way to do that and we try to do that there?
That
I wrote like we
yeah.
You have to get the
But another research question that I actually had derived from this study is we're trying to, if there is the link between the primary patients and their family caregiver, I can use this instrument to understand the implication to their families, to their family members' health condition in the following years or a few years, and that would be very interesting. Yeah, that's also a very exciting and interesting question to explore. Yes. And next one is more on the health system and health policy level that are trying to understand the implication of Medicare Advantage and accountable care organizations expansion on the use of post-acute care and the patient's health outcomes. And I won't talk into I won't talk in details about this, but you can read the paper, it's already published. And the three main findings is when the Medicare Advantage expanded in the market, the value of post-acute care among the traditional Medicare beneficiary decreased, and those reduction in the use of post-acute care actually didn't impact the average patient's outcome in terms of the mortality rate and readmission rate. And our results indicate that the policymakers should add the direct impact of MA and the indirect effect on the traditional Medicare patients, so-called spillover effects as well. And and some of the subtleties in setting up the accountable care organization reimbursement rate for the hospitals will also need to take into account the existing or the expanding effect of the MA in the local market as well. That's the that's the one of the example about the health policy research that I'm doing. And so the future research plan. So I really hope to leverage the research that I've and the evidence that I've collected so far to inform or set up a decision-making framework for the post-acute care discharge planning. And there are two faults. First of all, when there is really clear clinical evidence for what is the best setting for patients' health outcomes, we can try to study the payment models, the organizational structures to incentivize the institution and the insurance company to recommend the appropriate settings for the patients. However, when there are multiple settings that may be equally good, I want to incorporate the considerations such as the cost and the patient's preference into the decision-making and really tailor to the needs to family circumstances and conditions. And additionally, I would love to explore the care beyond the post-acute care stage, such as the specialty care and mental health care, the medication reviews, post the post-acute care episode and how that look like, and whether the different type of post-acute care have an implication on those type of services. And another thing that I would be excited about is to explore the disparities in access and utilization of post-acute care. Since in my first study, there's evidence for the disadvantaged group with insecurity jobs or lower incomes, sometimes would prefer the patients to go into skilled nursing facility settings. And in the literature, we have there are indications that the African American people actually are discharged disproportionately to skilled nursing facility settings. That indicates more by ethnicity instead of economic factors. So I really want to combine my study and the evidence that we observed in a real life, trying to understand whether there is a difficulty in access of care for certain type of populations. And also extend my post-acute care research into the long-term care space. And another passion that I have is to leverage machine learning methods or develop certain type of methods that tailor to the health services research that we do on a daily basis, and to have more power to understand those questions. Yes. The overall package, including the long term. Yeah, I think that would be interesting to explore in the future as well. Yeah. Yeah. Is that the integrated? Oh, sorry. Is the alternative name integrated care plan? For both I know there is an integrated care plan that developed for the dual eligible populations. While yeah. Mm-hmm. I'll look that up. But that would be really interesting to look into as well. Yeah. And yeah. Yes. Are there any questions online that I could answer? Oh, I see there is a chat. Yeah.
Good. I think it's yourself. Not just the whole group. Who do you see yourself collaborating with?
That's a great question. So one reason why I'm particularly excited about here is its potential and its focusing on the aging care, especially cross disciplines, and especially the clinicians here. It's actually what are most attractive to me as well. Since what I want to do is I really want to make actionable plans and to inform the decision making that's a clinical setting that and have different type of difficulties. I want to leverage the things that I learned to apply to those settings. So I think that's very important. And the method that I've learned through the economics or other method is to try to come up with a rigorous analysis, but the end goal is to inform the practice in those settings. So that's why I'm particularly passionate about it. And the people in the room have talked with a lot in the past few days or in the previous meetings. And I've learned all your work, everyone's work online, and read about your papers before. And I think there is a lot of potential for collaborations there won't be repetitive, it will be addition to the existing work that people are driving here, which is very exciting. And in terms of Colorado, people who have talked with me know I'm an outdoor person. And actually, I have a slide here. I love skydiving, kayaking, snorkeling, skiing, and those are all my things. And I haven't skied in this season since I'm afraid of getting injured. But that's the first thing on my list after I wrap up with the interviews. Yeah. Yeah. And yeah, I'm very excited about the post-acute care work. And there is a long going list about what can be tackled here. And you can see, like in the projects I listed here, there is the health policy, health system level angle to actually change the practice in post-acute care. But there are also the angle about understanding the clinical implications on the patients from those decision makings, and also what also the preference is trying to understand people's preference actually inferred from their family background, their living arrangement and condition. I think that's the first step to understand what those factors actually play into the decision, to the decisions in post-acute care, since the patients themselves probably know their situation the best. Yeah.
And one of the hardest and I understand the one specific yeah, those facilities but it is all of those things
Yes.
that become the most stressful thing.
Yes.
That
Agreed.
those facilities right they get down to the hospital.
Yeah.
So just crazy, you know, in light of that, what's the strategy to sort of that? Is there to move from those three experiences, stroke, heart failure, hip fracture, and then is there a strategy like what would you do to kind of give them apart what the right strategy?
You mean for different type of patients?
Yeah, people just it's not well tracked in data. All substances, and those are also
Oh, I see your point. Yeah.
Is there a strategy? I believe my state that exists where you're sharing law cases to work on.
Yes, I totally agree with the complexity and the difficulty that a clinician face, especially when they see a specific patient with all the information that they have. But I think part of my research is trying to push into that direction, and eventually we will be able to inform the decision making for post-acute care on a personalized measure. And it takes additional analysis to do it. And the study I've done from the second project is average effect for the stroke or for those three conditions that I explained. I aim to expand those to definitely other conditions as well, since the identification strategy or the method is there. I can expand that and run a whole list of the people who have a higher chance of discharge to post-acute care and see how that looks like, at least have a direction to where we explore, and then gradually adding into within certain patient groups, adding into the comorbidities and maybe some of the other indicators of the family support into that, and trying to understand what is the clinical implications from that. And yeah, there is a long pathway towards there, but I'm formally taking my steps. Mm-hmm. Mhm.
Other corridors, yeah, a lot of people would be in this care for this type of
Mhm.
the work in the hospital, not really you could check that, right? In the data, like, you not gonna limit your homework to people that have similar ways to stay, but also when you do discussions, it's just there in the hospital.
Mhm.
Right? Know that, you know. It's a great question, but then open up opportunities of different data sets within the system. Sure, big data, but what we have is the RTSU, what is that thing that's like the most.
And
Here, yeah, here's a, here, and then potentially within the option. Yeah, from Colorado. There's something.
I wonder those people who stuck in the hospital are they stayed in in the swing beds in the hospital, or it's a different.
Yeah.
Mhm.
I don't know how they.
How it works. Feel like we're stuck. You gotta look at the landscape. Overall, yeah, it's almost like. Just. And you rather, in a formal rigorous way, but instead. Often it comes out of like the qualitative study, no one wants to publish, even though it's really important. I actually think it's different points. Nuance with the references, and then a rigorous analysis. And I think they're on the way to getting there. Just like, this is like something. But it's just like right there. You know, and I think that's what it is.
Yeah.
Yeah.
Nuance. Whether it's stop.
Yes. Yes.
People are really sick, these are really sick people.
Mhm.
You're thinking average outcome of policymakers care about. But their policy decision is they're asking the wrong questions. You know, a lot of it.
Yeah.
Quality and somehow we will use that.
Yeah.
Right?
Yes. Yeah. Yeah.
But these are some of the fun things. Really great because, like, are there negative now? There's a very even now, they're even sicker people. Are they going to keep people recommending themselves? They're trying to do the work, right?
Mhm.
Are they creating like never back strength? They're kind of there, well, on the shower.
Mhm.
But
Yes.
like I think they did a really nice job of in the patient preferences and the policy choices to be a good with health, but I think it's really.
Mhm. Mhm.
In a sense. So the primary caregiver goes. And then if they come back and they're very sick, then you have to ask the next. Maybe that's like someone's son or whatever, right? And then you keep going out and you can actually expand all of the loss. Caregivers through just mentioning. And so. And all that stuff was like, you spoke to it, but there are new frameworks. So when you said that, it's well, I really would.
Yeah.
And I feel like I'm talking to utilities, it's actually like.
Yeah.
Yeah.
General, boards and engineers for taking that to the rest of the year.
Mhm.
Right, and so with that, the case, and they're like, another measure that who now have those health and health and their caregivers because their spouse got to do home health care. then like, what's the net effect for Medicare? Like,
Yeah.
And I get that, like, there's these problems, but if they're solvable, not feasible, I think that.
I think, yeah. We can solve that. And then we can solve it. I'm not saying you can address the question. Maybe not, I guess you could.
Mhm.
It's a break.
Maybe there's ways to, yeah, just come with that.
Yeah.
You just have to come here. You can do that, you can do this.
Very excited about all the work.
Yeah.
Thank you.
Thank you, yeah.